Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Welcome to the Spin Foundation course. Hope you're all having a great learning experience. For the next 15 to 20 minutes, I take your time to speak about viral infections. I have no disclosures. We'll start off with congenital infections, and once we say congenital infections, we think of the broad spectrum. And these viral infections are primarily transmitted across the placenta. So anything affecting the placenta or structures around the placenta are routes of entry for the pathogens into the placenta and into the fetal circulation. Once these pathogens enter the placenta, they affect the maternal side of the placenta, that is the maternal residua, the intervening extravillous trophoblasts, or the chorionic villi. The main objective is to disrupt these layers, enter the fetal circulation, and cause infection. Some indirect signs of infection before looking at the changes in the brain can cause placental thickening out there, oligohydramnios, pericardial effusion, diffuse cardiomegaly, pleural effusion and ascites, and also can have fetal head drops. So one must be aware of these changes, which can be markers of infection before looking at the brain. With that, to our first case, I thank also for the case. So this was a 32-week child who on the previous ultrasound had query of hydrocephalus. And you can appreciate that there is severe enlargement of the ventricles, there's cortical thinning out there, focal cystic lesions predominantly in the frontal lobes, possible malformation out there on the left frontal lobe, reduced dimensions of the orbits, reduced dimensions of the posterior fossa structures. Zoomed in images, you have microphthalmia, focal encephalomalacia with cortical thinning, some degree of polymicrogyria out there, and cerebellar hypoplasia. This child went on to have a scan after delivery, that is 1 month into delivery. Then again appreciate some form of dysplastic enlargement of the ventricles, multifocal lesions, predominantly clastic or destructive lesions, and a CT scan demonstrates periventricular deep white matter and some form of subcortical calcifications. Putting all together, the prime differential at this point would be congenital CMV. So CMV highlights that gestational age of the fetus at the time of insult can be more important than the nature of the insult. And why is that important? Because when CMV affects the fetus in the early second trimester or late first trimester, it can cause predominant changes of malformation, prominent calcification predominantly in the periventricular regions. Later on into second trimester, it has additional white matter abnormalities, less severe cortical abnormalities, can also have temporal lobe cyst, frontal cysts, and into the third trimester, the migration abnormalities are less expected, but you have these multifocal abnormalities of the white matter with a posterior to anterior gradient, parietal predominant, and hence the gestational age is important for the virus to cause various imaging manifestations from malformations to multifocal white matter structure abnormalities. So infections during the first trimester can result in congenital malformations, CMV the prime example, whereas those that occur in the third trimester or the postnatal period can have more predominant destructive lesions rather than congenital malformations. To a 3-week child with fever, seizures, and lethargy for 4 days. On the diffusion, you can appreciate there are areas of restricted diffusion in the bilateral temporal lobes, also the basifrontal lobes out there. T2, you have again corresponding edematous changes, right more than left, efface frontal sulci, and mild left region enhancement on the right side out there. So these changes in a 3-week child could point to a possibility of HSV encephalitis. As you know, HSV has two prime forms, HSV2, that is the neonatal presentation or the congenital presentation, and HSV1, that is the childhood and adolescent presentation. HSV2 in comparison to HSV1 is more diffuse, involves the gray and white matter structures, as you can see out there in the diffusion ADC sequences. Hemorrhage is less common in comparison to the HSV1 encephalitis. In the chronic stages, it can mimic somewhat of a hypoxic ischemic injury. Multifocal encephalomalacia can be seen. Whereas HSV1, more limbic system involvement, more hemorrhagic components, and very rarely affects the deep gray matter structures. So HSV2 and HSV1, different imaging manifestations based on the time of affection. The other torch infections, toxoplasmosis, usually a large head, ventriculomegaly. You have these periventricular and subcortical calcifications. Varicella can have ischemic foci as well as ischemic changes. Lymphocytic choriomeningitis resembles CMV in terms of classification pattern, but the ocular abnormalities are completely different. Zika virus, a more severe spectrum of the CMV type pattern, severe microcephaly, extensive malformation, ventriculomegaly, abnormal white matter structures, and you have these clustered calcification type appearance predominantly in the peripheral aspects of the brain. Do infections have patterns? Do viral infections have patterns? We'll have a look in the subsequent slides. So this is a 5-day-old with acute onset of fever on day 3 of birth, reduced feeding, seizures, and encephalopathy. And you can appreciate that there is a periventricular dominant pattern of cytotoxic edema, linear branching out appearance, extending up to the subcortical white matter. But the main changes are in the periventricular white matter and the deep white matter, also involved in the corpus callosum. And once we see this picture on a neonatal scan, we think of possibilities, and then we think of could it be pericovirus, influenza, coronavirus, rotavirus, enterovirus, or are all of the above a possibility? The answer is all of the above. All of the above are known to cause this pattern, that is periventricular pattern along the deep medullary veins. But the most common pattern or the most common organism is pericovirus. When you see these imaging abnormalities, think of pericovirus, but do not exclude the other viral organisms. Another pattern, ischemia, focal ischemia. Here was a 16-month male child with posterior movements of the right limbs. And you can appreciate that there is a stroke over there, predominantly involving the left MCA territory, paucity of the distal vessels or the middle cerebral artery on the left side. Vessel wall and contrast sequences demonstrated significant enhancement of the walls of the left middle cerebral artery. This is a vasculopathy, and this child had varicella infection 6 months prior. So this is a varicella or post-varicella arteriopathy. The organism can be latent in the trigeminal ganglion, predominantly in the ophthalmic branch, and on reactivation can affect the major vessels, most commonly the middle cerebral artery, but other vessels can also be affected. Usually it's around a latency period of 1 to 3 months, but up to 12 months can also be seen. So most important is clinical history, that when a child presents with stroke, post-varicella arteriopathy is the most common cause of arterial ischemic stroke in an otherwise healthy child. So ask for history of varicella chickenpox in the preceding 12 months of the event. Predominant basal ganglia involvement can be seen in few viruses, along with other structures being involved. Epstein-Barr virus is one of the most common causes of basal ganglia involvement. Rabies encephalitis, varicella can also have predominant basal ganglia involvement, but other structures can also be seen involved. Influenza, again, the deep brain nuclear structures are involved. You can appreciate multifocal abnormalities over there. More thalamic abnormalities, but the basal ganglia also are demonstrating these multifocal hyperintense changes. From the basal ganglia coming down into the posterior foci and the spinal cord. This was a 7-year-old with fever, diplopia, bulbar weakness, bilateral upper and lower extremity weakness. And you can appreciate on the T2H sequences that there are edematous changes in the dentate nuclei, the cerebellar white matter, dorsal brainstem, some degree of the pons over there, and long segment myelopathy involving the cervical cord and the upper thoracic cord. Axial sections demonstrated predominant central involvement and predominant ventral cord involvement. This child went on to have enterovirus, that is 71 strain. And when the brainstem structures and the cerebral structures are involved, think of Roman encephalitis. Many organisms can cause this picture, but enterovirus is one of the most common organisms causing this presentation. Spinal cord can have variable involvement. We'll focus on the ventral cord or the anterior onset involvement. Viruses can cause transverse myelitis, varial dorsal involvement, but anterior horn involvement, as seen predominantly in our case, can be caused by enterovirus, that is the D68, 70, and 71 strains. Polio, paricovirus, West Nile virus, Japanese encephalitis can also cause predominant ventral cord involvement. Cord aqua nerve root involvement can also be seen in viral conditions. West Nile virus over here, we have inflammation and enhancement of the ventral aspects of the cord aqua nerve roots, better demonstrated on the axial sections. Again, other viral organisms can cause cord aqua nerve root inflammation. Listed out here, enterovirus, coccidiovirus, ecovirus, more common than the others. More focal cerebellar involvement, a 2-year-old with acute onset fever, cerebral ataxia, neck pain, and torticollis. We have edematous changes in the cerebellum, right more than the left. And these were characterized as acute cerebralitis, and this child had, again, varicella. So again, cerebellar involvement can also be seen in varicella-related infections. Cerebralitis in general can be seen by affecting bilateral hemispheres, can be more predominantly on one side, more central involvement, can also have dorsal brainstem involvement. Enhancement can be variable. Over here you have diffuse retrovagal enhancement, and as outlined over here, many organisms can cause acute cerebralitis. Again, predominant viral organisms out there. When we think of virus web infections, we think of virus-associated encephalopathies, we think of immune-mediated infections, para-infectious etiologies. And these are relatively poorly defined, but they possibly reflect a combination of excitotoxicity with inflammation. And these range from febrile status epilepticus to the more severe spectrum, that is acute fulminant edema or multi-organ failure. We'll have a look at a few of the examples in subsequent slides. So it's a 12-year-old with fever, upper respiratory tract infection. And you can see over here on the imaging, there's a focal abnormality in the median aspect of the splenium of the corpus callosum. Diffusion, hyperintense cytotoxic edema, T2N flare demonstrates these hyperintense changes. And this was the case of H1N1 influenza virus. We term these as cytotoxic lesions of the corpus callosum. They can be focal, they can be confluent. More commonly, the focal pattern. This is due to glutamate excitotoxicity caused by the organism, the viral pathogen, which results in these edematous changes. Clinically, they can be termed as MRSA, that is mild encephalitis or encephalopathy with reversible splenic lesions. A great paper out there. And these can be caused by multiple abnormalities. Infection is the most common cause, seizure is another cause. And infections, these are the viral organisms which are known to cause or commonly cause this imaging manifestation. Again, influenza, HHV6, rotavirus, mumps, measles, again common causes. Here's a case of a 7-year-old female child with febrile illness, seizures, and encephalopathy. This child had IgM dengue positive. You have extensive abnormalities involving the subcortical white matter, also some degree of involvement in the basal ganglia. And this was a child presenting with acute leukoencephalopathy reduced diffusion. The two main drivers can be infection and toxic related causes. And in infections, virus is one of the most common causes. The initial MRIs, at least in the first 2 to 3 days, can be normal, whereas later on, because of the possibility of seizures, prolonged seizures, these children can have extensive abnormalities, predominantly affecting the peripheral regions of the brain. It can be central sparing, as seen out here, known to have better prognosis, or as seen in our case, diffuse extensive abnormalities affecting the bilateral hemispheres. To our next presentation, it's an 8-year-old with fever, severe encephalopathy and liver dysfunction. The primary abnormalities are in the deep brain nuclei, that is the thalamus. You have variable degree of edematous changes, some degree of cytotoxic edema out there, peripherally some degree of vasogenic edema, punctate foci along the bilateral hemispheres out there, and on the SWS sequences, there's possibly some hemorrhagic components in the bilateral thalami, right more than left. And once you see this picture in a child with the febrile illness, we think of acute necrotizing encephalomyelitis or encephalopathy. These are diagnostic criteria for A&E. I won't go in detail, but the first criteria outlines is acute encephalopathy following a viral febrile illness. So more commonly, a viral illness is a trigger for this imaging presentation. Thalamic abnormalities can be seen caused by other viruses. Dengue encephalitis is common. Hemorrhagic abnormalities, ischemic and necrotic abnormalities in the bilateral thalami can also involve other structures of the brain. Influenza virus again can have bilateral thalamic involvement, and Japanese encephalitis can have edematous changes again affecting the thalami in the form of ischemia and necrosis. They can also have hemorrhagic changes. We have seen acute, subacute presentations. This is a more chronic case over a period of 2 years. This was a child with a 14-year-old. Initially had high-grade fever, recurrent seizures, and altered sensorium. And these are the scans after 2 years of the illness. And you can appreciate extensive white matter changes, deep brain nuclei changes, right more than left, and multifocal cystic abnormalities or cavitated lesions in the bilateral hemispheres. Post contrast, there is some degree of enhancement of the cortex and some of the cystic foci. This child turned out to have measles antibody positive and was a case of SSPE. So that was slightly atypical presentation of an SSPE. So this is the more common presentation of SSPE. On imaging, the first few months of life of the symptoms can be normal. Into the first year, it can have predominantly subcortical deep white matter involvement, again posterior predominance. Into the second year, more periventricular extension of the abnormalities. You start to have neurodegeneration, and after second year, extensive abnormalities involving the white and gray matter structures and severe cortical atrophy out there. That was the usual, the atypical, the unusual or the atypical. They can have temporal lobe subcortical cysts, frontal lobe cysts. As you have seen in our case, multifocal cystic lesions. Predominant basal ganglia involvement, can also have brainstem and middle cerebral peduncles or cerebellar involvement. So one needs to keep in mind the atypical presentations along with the typical presentations. Before I conclude, before the imaging patterns, the clinical patterns, it is also important to know which viruses have selective mechanisms of entry or mechanisms of infections. For example, varicella, the latency period, the reactivation which causes stroke. Then also look at which area you're practicing in. Some organisms are more prevalent in some regions of the globe, and some of the viruses are vector-borne viruses. So some animals are specifically carry these organisms. To a knowledge of these organisms also is important. For example, Japanese encephalitis has predominant areas affecting the Southeast Asian belt, the Indian subcontinent. So geography also can be important in diagnosing these conditions. Thank you for your attention. I would like to acknowledge the entire SPIN team, Dr. Balthazar, and the Rainbow Children's Neurology team.